Welcome everyone who's joining us for this event organized by GARDP, the Global Antimicrobial Research and Development Programme, as part of Antimicrobial Awareness Week. My name is Claire Dool and I'm your moderator. Antimicrobial resistance is one of the world's biggest killers, claiming more than 1.3 million lives every year, as this short video shows.
The discovery of antibiotics transformed our world. Previously incurable diseases are treatable. Medical procedures can be performed safely. Millions of lives have been saved and their well-being radically improved. But time with these drugs is running out. Antibiotics have been used so much, many infections are once more untreatable. Drug-resistant infections are already responsible for nearly 1.3 million deaths a year. Without urgent action, this number is projected to increase exponentially. Drug-resistant bacteria know no borders. Everyone is at risk, everywhere. Your family, your neighbors, your colleagues. We can prevent a post-antibiotic era by taking action now, together, with urgency. GARDP is a non-profit organization accelerating the research and development of life-saving treatments for drug-resistant infections, for every person who needs them, to protect our health now and for generations to come.
Everybody is vulnerable to AMR, but children and newborns are especially vulnerable. 1 in 5 deaths caused by antibiotic resistance occur in children under the age of 5, and up to 3 million newborns get serious infections that lead to sepsis every year. Some 570,000 die from sepsis every year. Many of those deaths are because the infections have become resistant to standard antibiotics. But the development of new antibiotics is not keeping pace with rising antibiotic resistance. When it comes to developing treatments for children and newborns, the situation is even more dire. Over the next hour, we'll be looking at putting children and newborns first and discussing how to ensure better outcomes for this vulnerable population group. We would love to hear from you. So please do put questions and comments in the questions section you can see on the slide here. And of course, do tweet using @GARDP or the hashtag WAAW2022. As you will see on the slide, the webinar will be recorded and you can find it afterwards on the GARDP website. But with no further ado, let me introduce our very, very distinguished and informed panelists. Please welcome Subrasri Srinivasan, who's the Medical Director of GARDP, Alex Costa, a Senior Health Advisor at UNICEF, Christina Obiero, Clinical Researcher at the Kemri Wellcome Trust Research Programme in Kenya, and Nishad Plakal, Professor of Neonatology and Associate Dean at the Jawaharlal Institute of Postgraduate Medical Education and Research, Puducherry in India. And Christina and Nishad have both taken part in the GARDP observational study of newborns with sepsis and will be taking part in subsequent drug trials, more of which we're going to hear about later. But before we do, let's briefly set the scene. Suba, just tell us very briefly why this focus on children and newborns with drug-resistant infections.
Thank you, Claire, and greetings to fellow panelists and all of our listeners. GARDP's mission is to develop and deliver effective antibiotics to everyone who needs them. And what this means is that we work in areas with the greatest need. And this need could be defined in terms of populations, it could be defined in terms of geographies, or the kinds of infections or the kinds of resistant infections that we are talking about today. And globally, children constitute roughly about 1/4 of the population. However, based on a recent Lancet study that was published last year, they are disproportionately affected by antimicrobial resistance. And this is because they are a very vulnerable population. And when you look at this a little bit more carefully, it is pretty obvious that this is predominantly a low and middle income issue. When you look at deaths in children under 5, they are almost all in low and middle income countries. Indeed, almost more than 99% are concentrated in these countries. And what's more is that half of these under 5 deaths are really in newborn babies, neonates. And this is very striking. And as you already pointed out, almost 3 million babies die each year of neonatal sepsis, which is this overwhelming infection very early in life when they are still not able to fight off these infections. And again, the burden of this is really in low and middle income countries. So clearly, for us, children are a population that are grossly underserved right now, highly impacted by antimicrobial resistance. And to add salt to this wound, there is a distinct lag in development of antibiotics for children. So currently, for instance, this year, there were 43 adult antibiotic clinical trials that were recruiting patients. Comparatively, there were just 10 trials in children, and of those, only 6 were recruiting newborns. This really says that this neglected group needs a lot more, awareness, which is what we are doing here, but also work to correct this situation. And this is why, children's antibiotics are a huge focus area for GARDP.
Yep, Suba, absolutely. As you say, a very vulnerable population, especially the newborns, and a great burden in lower and middle income countries. Alex, you're a senior health advisor at UNICEF. And as Suba was saying, there's a big problem of drug-resistant infections with newborns. And I believe that you've actually seen this in some neonatal wards that you visited. Tell us what you saw.
Good morning, good afternoon, good evening, everybody. Several years ago, I was part of an outbreak investigation in Southeast Asia, and I visited the pediatric hospital in the capital, where I was stored around the neonatal ICU. There were 2 of them, and there were roughly around 30 infants, preterm, full term, who were in the neonatal ICUs. With the name tags, which showed the bacterial infection they had and the pattern of resistance they had. And I did ask those who were touring me around what was the mortality rate. And the answer was, well, accumulated, it's around 50%. There's a difference when you actually see this written on a piece of paper and when you actually see it with your own eyes. Because it felt so strong that I felt like I had been punched. And it took me a moment to actually recover from the fact that 50% of the infants around me would not survive. Not only because of drug resistance, but because there were very few alternatives left, such as colistin, which is highly toxic. So what they told me was they're either going to die because of resistance, so we cannot actually treat the infection, or because of toxicity associated with colistin.
UNICEF, of course, very concerned about these newborns, but also about the spread of drug resistance in children under 5.
Yeah, so if you actually look at the recent data about mortality rate, causes of mortality under the age of 5, infectious diseases remains the leading cause of death. For example, that's pneumonia, malaria, HIV, and sepsis. So you can estimate that a significant proportion of under 5 mortality will be impacted by antimicrobial resistance, or is impacted, because infectious diseases is the leading cause. But then, in reference to the grim report that Suba was talking about, we know that 1 out of 5 children globally are victims. So globally, if you look at the number of deaths associated with antimicrobial resistance, 1 out of 5 are in children under the age of 5. If you look at sub-Saharan Africa, the numbers are worse. It's actually 1 out of 2 deaths associated with antimicrobial resistance are in children under the age of 5. So this is a significant problem. It's one of the major killers globally in children under 5, and therefore we need to address this head on. And if you actually think in terms of sepsis specifically, we know that sepsis could be caused by community-acquired infections or hospital-acquired infections. But those that happen in the hospital or in the healthcare facility setting are much more likely to be resistant, which makes it very difficult to treat.
Absolutely. And of course, AMR is going to reverse many of the gains, isn't it, with the Sustainable Development Goal 3 on reducing childhood mortality.
So the SDG target 3.2 really is focused on newborn and child mortality. It's basically looking at under 5 mortality and newborn mortality. And it's estimated that 30% of the cases of sepsis in newborns, which is about 214,000 babies, are due to bacterial infections that are resistant to available antibiotics. So one of the statistics is that, which is quite striking, every 3 minutes, a child dies, an infant dies of a bacterial infection that's drug resistant. And these numbers are increasing, not decreasing. So we're really dealing with something that's very important, very critical.
Yeah. Yes, very critical, as both Suba and Alex have said. And we're now going to bring in 2 doctors into the conversation who face on the ground some of the challenges of treating newborns, neonates, as they're called, with sepsis. Nishad, in India, in your hospital in Puducherry, can you briefly paint a picture of the challenges that you face when you're treating newborns with sepsis?
Thank you, Claire. So our unit is in the public sector, and it's among the largest units in the country. And we predominantly cater to a relatively poor population. So we have problems with increased infection rate when compared to Western units. But what is worse is that there are increasing rates of antimicrobial resistance also. Just a few months ago, we had published data from our own unit, and when we looked at it, more than half the infections were caused by bacteria that were resistant to multiple antibiotics, about 55% actually, and 40% of those babies died. So the numbers were similar to what Alex was mentioning. Nearly half those babies died. So this is an increasing problem in our country, and just as in other low and middle income countries. And of course, we have major issues with resources. For example, nurses. A nurse in a Western unit would be taking care of one very sick baby, 1:1 nursing, but it's not unusual in my unit for one nurse to take care of 4 or 5 very sick infants at the same time. So that means they have less time to focus on things like hand hygiene and maintaining aseptic precautions when they're doing procedures on the baby and such things. And of course, there is a question of money. My unit generally provides drugs for free, but that's not the case everywhere. And occasionally, we do have to prescribe expensive antibiotics that they have to buy elsewhere. And that can be a problem for parents when they have to buy expensive antibiotics. And many of these newer antibiotics are very expensive, and we are forced to use them because of antimicrobial resistance. So those are some of the issues that we face.
Yeah, Nishad, absolutely. So resources, training, infection control, overcrowding, and of course the expense of antibiotics, and this issue that many of them are now resistant and don't work. Christina, you're working in a hospital in Kenya. Do those challenges that have been outlined sound familiar? And what other challenges do you face in your hospital?
Yes, Claire. So the challenges Nishad has alluded to are familiar with the ones that we experience in Kenya. So I work in Kilifi County Hospital, which is a typical Kenyan district hospital, and was renamed to be known as a county hospital following devolution of healthcare from the national government. And Kilifi County Hospital has additional support for pediatric care from the Kemri Wellcome Trust Research Institute program. And on average, you admit about 1,300 babies annually from either a maternity ward or from the community. So despite the availability of additional clinical personnel, laboratory and treatment resources, our neonatal mortality remains higher than could be achieved because of various challenges that we continue to face. And this include limited availability of routine availability of high-level antibiotics such as carbapenems and piperazole tazobactam due to cost constraints. And then you also have overcrowding and limited staffing within the neonatal unit. And this actually contributes to the spread of infection and outbreaks. In addition to this, we have we lack availability of tests which have high specificity for detection of those organisms that cause neonatal sepsis. So as much as we're able to perform blood cultures for all babies who are admitted to our unit, we still have the low expected yields of about 6% with contamination rates of about 10% or more. And the fact that you can provide cultures to all admissions is a very unusual case in the typical district hospital in Kenya. So the other challenge that is faced in county and sub-county hospitals has to do with the clinicians relying on generic pediatric protocols for management of babies. These protocols were developed for use in the very low-level health facilities, and they are not. They lack antibiotic treatment guidelines, which are based on local susceptibility profiles.
Yeah. So all of these challenges, Nisha, just in a sentence or two, what's it like when you know that the antibiotics would help the newborn, but you either don't have them or the newborn is resistant to them?
I think you just described some of the most frustrating experiences that clinicians can have, Claire. So antibiotics work and they are life-saving, but the point is that you need to start them early enough, and two, they should be the bacteria should be sensitive to those antibiotics, and we have a problem with both, as Christina was saying. Sometimes we have a problem testing these babies, finding out if these babies are septic, or even having a physician look at the baby and suspect that the baby is infected early enough to start antibiotics. And of course, then if we have drug resistance, it is very frustrating to watch a baby die who could have been saved. And that is part of what came out of the observational study that we did too.
Yes, and let me pick up on that, our observational study, which GARDP has set up. It was one of the largest ever on the care of babies with sepsis in 19 hospitals in 11 countries. And in the hospitals where Nishad and Christina work, they took part in this. But first of all, we're going to hear a short video, and we're going to hear from a doctor involved in the study in a hospital in Uganda.
I'm Dr. Flavia Namiro. I'm a pediatrician based in the neonatal unit. Neonatal sepsis, it's an infection of the blood. It is something to do with their environment or where they are coming from. So sometimes mom has a blood infection during pregnancy or shortly after birth, and this may pass on from the mother to the baby, but also during delivery. One of the challenges we have is really making a diagnosis of sepsis in the neonates. It is not readily available everywhere. That treatment is available. The biggest challenge now is the common drugs are few, but with also very high resistance. So finding options is becoming harder and harder every day. And moving on to second line, the cost increases. Not everyone can afford it. So the neosepsis study was a good eye-opener. Something interesting about the study was we were able to fully investigate the babies and ensure they got the antibiotics. We worked hand in hand with the other clinicians that were taking care of the babies, so that drugs were readily available for the babies. Sepsis kills. That's why we need to recognize it and treat it promptly and correctly.
There we are, and I'd like to encourage our speakers to put their cameras on again. So we know that this study followed some 3,200 newborns, and just first of all from you, Nishad. Your hospital actually took part in the study. What struck you about what you found out and your findings?
So, Claire, the headline number was that 1 in 9 of those babies died. So we had over 3,200 babies in these 19 centers, and 350 of them died. So that number was not unexpected, more than 10% of these infants dying. But just the fact that it's not unexpected says something. We are not surprised anymore to hear about such large number of deaths, because that seems to be routine in babies, when actually these are preventable deaths. Deaths due to infection, which is preventable. So most of these deaths, I would say, are preventable. At least many of these deaths are preventable. One striking thing that we noticed in the study was the wide disparity in outcomes between different centers. The death rate was as low as 1% in some centers and as high as 27% in others. So this is a problem in low and middle income countries, that different populations have different levels of access to healthcare. Some have access to world-class healthcare, and others just barely have access to a physician. So some differences could have been due to differences in the kind of sick babies they admit, but I think a lot of it is due to disparity in healthcare access also. So another thing that came out of the study was that we were able to evolve a score for sepsis. So that helps us to predict how likely a baby is to die based on the risk factors that we observe. So that could actually help us when we are discussing the outcomes with parents, and also could help in future drug trials. We could probably see how the baby is doing on an antibiotic, whether the baby's score is improving or worsening. It potentially could help us in drug trials also.
So some very important findings out of that observational study. Christina, you took part in that observational study. What did you learn from the findings?
So one of the things I learned from the findings of this study is that there's a very wide range of antibiotic regimens or combinations that are used across different settings in LMICs. What we saw is that there are more than 200 different antibiotic combinations that were reported to being used as treatment for babies who have sepsis. And of this, only of all the babies that were involved in the study, only less than a third of those babies were started on a first-line treatment regimen that was based on penicillin, as is recommended by the WHO. And so these findings really underscored the urgent need for a well-designed antibiotic trial, which is aiming to optimize treatment in babies who have sepsis, and is aiming to also address the key questions related to different standard of care antibiotic options across different settings, and differences in the burden of antibiotic resistance across different settings, and to also address questions related to how clinicians can make decisions on when to change from first-line to second-line treatment in babies who have sepsis.
So absolutely, all of those findings from that observational study are going to feed into a new trial that I know Christina and Nishad, both of you are going to be involved in. And I'm going to come back to you in a moment, but perhaps I should go first to Suba, who has obviously been very involved in the observational study and is now setting up this neosepsis trial. So Suba, yes, how do the two link, and can you tell us how you're designing the trial? It was quite shocking what Christina was saying there about how many different combinations of antibiotics are being used, and none of them, of course, are on the WHO recommended list for this. So Suba, yes, a few words about how the study and the trial link and how you're designing the trial.
Sure. So I think it's always best to hear from the clinicians on the ground, in terms of the issues and the findings from the study, and really putting that in the right context. And what's important to understand is that GARDP works in partnerships. We don't work, but as a sole entity. So our children's antibiotic partnership is with St. George's University of London, the MRC in the UK, and Penta. So we are a four-party consortium that works, that is going to work on this problem of neonatal sepsis. And I don't have to belabor the point that this field is in dire need of awareness, advancement of the science, and solutions. So that we are going to do all of those. At least that's the goal. So in setting up the observational study, while on the one hand we collected a large amount of data prospectively, high quality data that will help us kind of work out some of the issues that people are talking about, it also helped us understand clinical trial capability, in these settings. These are low resource settings, as has been already talked about. And so setting up clinical trials in these settings has to be done in the right way. You cannot just take something that's done in a high income setting and hope to replicate it in these settings. You need to adapt and contextualize. And so the observational trial really provides us with those inputs needed to plan an interventional trial. Now, what Christina pointed out is a very key factor, that the WHO currently recommends ampicillin and gentamicin as the empiric treatment for neonatal sepsis. And as she said, only about a quarter of the sites in the observational trial were really using those kinds of regimens, which means that the standard of care has shifted in many centers just based off of their own experience, rightfully so. But then the local epidemiology is so variable between centers that we cannot land on one single standard of care. So to conduct an interventional trial, you need a control. You need to compare it to something, right? And so we cannot impose one single standard of care across the globe. So the way that the consortium has has dealt with this issue is to come up with this really innovative way of designing the interventional trial, where every site will have a menu of options to pick from regimens that they think are the most appropriate for the babies in their units, based on the microbial epidemiology of that unit. And in this way, babies will be randomized to care, but they will be getting regimens that potentially are effective. And so the trial will look at many regimens, will also seek to validate the scores that both Nishad and Christina talked about, the neosepsis score, the recovery score. Will also give options to switch antibiotics and make sure that the timing of that switch is correct. And then we'll follow outcomes. And ultimately, the goal is to rank order various regimens. GARDP is going to study potentially three regimens that are combinations of older antibiotics. We have studied these older antibiotics in combinations in the lab and shown that, in fact, some of these antibiotics could be very potent against some of the bacteria that we're talking about that are really highly resistant. And this is important because there is, on the one hand, a lack of good solutions. On the other hand, overconsumption of really last line antibiotics that we want to conserve. And so the trial itself will be innovative and groundbreaking in its own, just by design. But also at the end of the day, we hope that we'll have regimens that we can then take and, take to the WHO as recommendations for empiric treatment for neonatal sepsis.
Yeah, absolutely. It's important that those guidelines are updated. I believe they haven't been updated for 50 years or quite some years, so they'll be waiting for your evidence. Just a few words then, Christina, because I understand the neosepsis trial is going to begin in South Africa and then it's coming to Kenya, and you're the principal investigator for the trial in Kenya. How are you preparing for it? What do you have to put in place?
So I'll just start by saying that we previously performed the initial fosfomycin pharmacokinetics and safety trial in Kilifi. And we also did some lab work to examine the susceptibilities to fosfomycin of archived.
Is one of these combinations, isn't
exactly, it? Yeah, yes. It's one of the off-patent antibiotics that's going to be investigated in the NeoSep trial. So we did some lab work to examine the susceptibilities of fosfomycin to archived invasive isolates in Kilifi. And the data we obtained from these studies provided us with very important information on the fosfomycin in babies who have sepsis. And so now, as a principal investigator of the NeoSep trial in Kenya, working with GARDP and central coordinating teams who are based in at the St. George's University of London and at the Medical Research Council clinical trial unit to prepare our site for the first phase of the trial. So the first phase of the trial is going to be a confirmatory pharmacokinetic phase, whereby you're going to be looking at 3 different antibiotic combinations that consist of 2 off-patent antibiotics, that is fosfomycin and flomoxef. And to prepare for this phase of the trial and eventually for the second phase, we are currently undertaking several activities, which include obtaining ethical and regulatory approvals for trial implementation. We're also preparing trial documents, working on getting the investigational medicinal products to the site, and also training the staff.
So lots of work that needs to be done there. Nishad, in India, you're also the coordinator of the trial, which I believe will start in 2024. As Christina said, there are ethical considerations. You have to get consent. How challenging is that, given that it's newborns that are your target group?
Yeah, so that is going to be a major challenge, Claire. Sorry, I got disconnected for a while there. The problem in doing drug trials in newborns is one that they are considered a vulnerable population, and rightly so. They can't give consent as patients to be enrolled in a study. Parents have to give consent. They are smaller, they react differently to drugs. We have to find out different drug dosages for them. They could have unexpected reactions to drugs, which we sometimes can anticipate, sometimes cannot. So that makes it very challenging to get drug trials done in them. But those are also the same reasons why we need to do drug trials in these babies. We can't extrapolate what we find in adults and older children to newborn babies, because they need different drugs probably, and sometimes different doses of drugs, different dosage regimens of drugs. So the only way to really find out is to study drugs, new drugs in newborn babies, but in the context of a well-conducted clinical trial with strict safety measures and good monitoring and all that. So I think that's what's planned to, that's what is expected to happen with the trial that's going to start in sometime in 2024.
Yeah. Well, Christina and Nishad, good luck with both of those trials. Very, very essential, even though they are challenging. Suva, so GARDP with its partners, of course, is involved in those trials, but you're also involved in developing a new antibiotic, cefopemetanibobactam, if I pronounced it correctly, which is for serious infections in children. That's part of a partnership that you have with a biotech company, I think. What sort of infections are you hoping that that new antibiotic will be able to treat?
Sure. Thanks, Claire. So yes, that antibiotic that you're referring to, cefepime taniborbactam, is a novel antibiotic that's being developed in partnership with Venatorix Pharmaceuticals in the US. And they have just concluded their trial in adult patients and are looking to submit their application for approval in the US. What GARDP has observed, and this is and others as well, is that there tends to be either a lack of development of antibiotics for children, or a very big delay in development of antibiotics for children. Indeed, of the 40 antibiotics that have been approved for use in adults since 2000, only 4 have included dosing information for neonates. That's very telling. And as Dr. Nishad was saying, neonates are not little adults, and they're not even little children. They are quite distinct, and you really need to understand what is the right dose in neonates. And the way to do that is to actually dose them and to really understand, are you giving them enough? Are you giving them too much? I mean, these are little things. Overdosing could be quite a catastrophic issue. And so the only way to do that is to actually conduct well-designed, rigorous trials and to look at the pharmacokinetic data and then correlate that with what will define efficacy and of course safety. And so GARDP is committed to ensuring that in the partnerships that we are in, that antibiotics will be developed for children, and not as an afterthought, but really parallel to what's being done for adults, so that there's a timeliness in delivery of these antibiotics, and not just for children, but for newborn babies as well. So in light of the development, the partnership with Venatorix, we are fast tracking the development of cefepime taniborbactam for children. And this is an antibiotic that will treat highly resistant gram-negative infections, and a particular class of resistance that is becoming highly prevalent and really has no other options other than highly toxic drugs such as colistin. And this is the bacteria, gram-negative bacteria such as Klebsiella, that produce this enzyme called metallobeta-lactamase. And really, there are no good options today for this kind of infection. And the highest prevalence of these kinds of infections are, in fact, in the units that Dr. Nishad and Dr. Christina work in. And so this is where GARDP hopes to sort of bring together our mission, as well as acceleration of development of newer antibiotics for children and neonates, all together, one place.
Absolutely. So you've got the trials going on with the existing antibiotics, getting the right combinations. You've got this new antibiotic that indeed you want to make sure that you have the right efficacy and dosages for children. Big question, and we'll bring Alex into the discussion too, because of course UNICEF is very involved in procurement. But Suva, how are you going to make them more available? What if you get the right combinations, if you get this new antibiotic right for children? The question is availability and access.
I think that's a $1 million question, right, Claire? And so I just want to point out, this has not been done for antibiotics so far. Excuse me. In the case of HIV, for instance, tuberculosis, malaria, there have been many attempts to bring these newer drugs to the countries that need them the most, and very successfully so. But this has not been done for antibiotics, and GARDP is really at the cutting edge in this regard. And it is part of our mission to make sure that the antibiotics we develop are also delivered, in a timely way to the regions that need them the most. And of course, we are also very conscious of the stewardship aspects of access as well. And so all of our development agreements with companies, with pharma companies, really have embedded access initiatives into those agreements. And the goal is really to potentially cut these delays from decades to years. And our, most recent partnership, a collaboration agreement that was signed with the Shionogi pharmaceutical company in Japan, the Clinical Health Access Initiative, or CHI, is to provide access to a new antibiotic, cefiderocol, which has been approved in the US and Europe, to many other countries, middle and low income countries. And really, this is another very good antibiotic that can provide an option for highly drug-resistant pathogens. In doing all of this, I think we want to tackle the urgency that is in these countries and provide access, but also tackle availability, affordability. It's all of those aspects that we want that will come through in these kinds of initiatives.
So Suba, of course, as you say, you're building in access to the contracts, the partnerships that you have with drug companies. You're also, I understand, involved with UNICEF and WHO in a new initiative to get access to a whole range of antibiotics, a whole portfolio of antibiotics, the SECURE initiative.
Yes. So SECURE is an initiative that's still in concept form and is being built, and essentially it aims to provide access to a portfolio of essential antibiotics, and it's not limited to just the newer antibiotics. It's really much broader than that. I mean, we are also aware that there are many antibiotics in shortage today that are essential in many parts of the world, and this is bad because what happens is if you have a shortage of an essential antibiotic that's probably a little bit lower in terms of its spectrum, for instance, and could ideally still be used and be very effective, but then you cannot use it because it's not there, then people revert to the more higher level antibiotic, which then creates more problems in terms of resistance and so on. So provision of the right antibiotic is also just as important, and some of these supply chains are broken. There's not enough manufacturers. For instance, a couple of years ago, there was an antibiotic called piperacillin tazobactam, which is used very widely to treat sepsis, also in newborns, which was manufactured just in one factory in China, and something happened and that supply chain was broken. And many centers then reverted to using meropenem, which is a much more potent antibiotic and an end antibiotic. And this is just an example. So SECURE will also look at sort of making sure that those supply chains for older antibiotics remain robust, and and provide a way of procurement, for countries of essential antibiotics that will support their health systems. And this is really a consortium, as you referred to, is really along with WHO, with help from UNICEF and CHI.
Yes, and what help, Alex, is UNICEF going to be offering to SECURE? It's an initiative that's under development, as Suba has said, but obviously a very important one.
Yeah, indeed, it's quite important because we know that in low and middle income countries, access or delayed access to antibiotics can actually kill more than antimicrobial resistance or antibiotic resistance. So in simple terms, we're still in the conceptual phase, but in simple terms, GARDP would be responsible for actually generating the evidence that would then inform the WHO to update guidelines and provide recommendations of the use of these drugs. And then UNICEF would step in to use its procurement mechanism in order to procure and distribute these drugs, especially in order to increase access in low and middle income countries. In addition, we can use our procurement mechanism to ensure the quality of these antimicrobials, because counterfeit drugs, substandard drugs, are a very common issue. So if we actually use our procurement mechanism, we can ensure the quality of these drugs and also use the procurement mechanism for market shaping based on the sheer volume of what we can procure and economies of scale. And I think programmatically, UNICEF can also support strengthening national stewardship programs. Since we're a frontline organization working at the community level, working at the primary healthcare level. So there's a possibility of actually improving the stewardship of these drugs at the very point of care.
Which is obviously, as Suba's saying, really important, because if you have more access, you've got to make sure that the antibiotics are correctly used. Indeed. We've got lots of questions coming in. So let me go to our...
Can I make a final comment on this, Claire? Exactly what you just mentioned. I think access and stewardship are two sides of the same coin. They can't be really separated. If we increase access without proper stewardship, we will eventually lead to resistance down the road. So I think it's very important for governments and stakeholders on the ground to take ownership of their stewardship programs and improve their regulations and the application and strengthen these stewardship programs in order to safeguard these drugs, not only for themselves, but for everybody, because we're globalized. What happens in one country affects everybody.
Absolutely, two sides of the same coin, as you said. Let me now go to the audience questions, and we've got quite a few. Perhaps, Suba, this one is for you. You were mentioning Shionogi, and the question is regarding the access to Shionogi product. Have the unmet needs in terms of metallo-beta-lactamase epidemiology been mapped to understand where the unmet need for this product exists?
Excellent question, and I think that's where GARDP comes in, is to really start to map some of these kinds of issues. I mean, there is data from surveillance that's done, you know, in many parts of the world. However, the data is very spotty, and more importantly, you know, how representative is the surveillance data of actually what's going on the ground in the clinics? I think that's the big question. And so we are just right now, in fact, in the process of setting up another observational trial, this time in adults, at centers in India and South Africa, to try to understand, you know, what is going on over there. In terms of serious gram-negative infections. We also have, you know, a collaboration with PAHO in you know, Latin America to better map out, you know, where are the pockets of infection in that region of the world. And we will continue to do this in partnerships, trying to detail, you know, where the unmet needs are. And for everything that we do, this is we try to generate the evidence for the need, and then generate the evidence for the effectiveness of whatever intervention that we want to bring.
Thank you very much, Suba. A question now for both of our doctors, perhaps Nishad first and then Christina. To what degree does the variability in treatment regimens reflect access challenges? You were all saying that there was the NeoAW study showed the variability in treatment regimens. So to what extent does that reflect access challenges to recommended penicillin-based antibiotics versus actual need for alternative regimens? And how would you propose to address this? Nishad and then Christina.
So access is something that cuts both ways, actually. So one of the drivers of antimicrobial resistance has been probably overuse of antibiotics in India and in many other places. Sometimes even potent antibiotics are available over the counter without prescription and are abused in many settings. So access probably works both ways, and in, like I was saying, in our center, most antibiotics are available, and I like to think they are used a bit more responsibly. But there are clearly centers in which access is a problem, even in India and of course in other countries. But that said, access is not the only issue. There is, I mean, like I said, even in our center, more than 55% actually of the bacteria causing infections were resistant to multiple drugs. So the WHO recommended regimens wouldn't work on them anyway. So apart from a question of access, there is genuinely a need to develop newer drug regimens which work against these bacteria so we can save the babies.
Christina, what's your view on the variability in treatment regimens and whether it's due to access challenges or to the actual need for alternative regimens?
I do agree with what Nishad has said regarding the role that access has to play with regards to development of resistance and also options that are used for treatment. I had mentioned earlier that in our center, we have limited routine availability of high-level antibiotics such as carbapenems. And most of the time, these antibiotics are available due to support from the research program. If that wasn't available, then babies needing this treatment would not be able to access it. One of the interesting observations we had during the NeoOP study was that we had the first neonate who was admitted to a hospital as a referral from a peripheral health facility with infection caused by a bacteria, a Acinetobacter species that was resistant to carbapenems. And this is a premature baby who was referred, and the mother had been in labor at the peripheral health facility for some time before coming to us. And we clearly know that this is a health facility where such antibiotics are not accessible and are not used. But we also need to keep in mind that the community does have a role to play when we talk about development of resistance in our setting. Yeah.
Christina, you were mentioning diagnostics and the lack of diagnostics for neonatal, for newborns. A question here, perhaps you can answer it, otherwise if anybody else can, please just raise your hand. What is the role of low-cost rapid molecular diagnostics in low and middle income countries to curb antimicrobial resistance?
Maybe
okay,
Alex.
There we are, Alex. Thank you very much for catching that ball and that question.
Yeah, well, it's my pleasure because in addition to being the focal point for AMR at UNICEF, I'm also the focal point for diagnostics. So I think a point of care diagnostics will continue to play a very important role in improving its stewardship. One of the problems we have, I think, is a technological bottleneck. You know, very often when we talk about microbiological testing, for example, antibiotic susceptibility testing, it happens in a laboratory setting. So we need to improve. It's not even access because it's a technological bottleneck, but we need to develop and improve access to diagnostic tools, especially simple ones such as rapid diagnostic tests that can help make that can help improve stewardship. So a simple decision whether this is a viral infection or a bacterial infection that comes out of a rapid test will significantly improve stewardship of antibiotics. Point of care molecular testing is these technologies are actually increasing. COVID-19 really created an opportunity here. The pipeline for point of care and near point of care molecular tests is very rich right now. There's a number of new technologies coming into the market relatively soon, and many of them will actually be used for antimicrobial resistance. So I think there's an opportunity here. We should all keep our eyes on it because these technologies are coming into the market very, very soon. And I think we should leverage them to the extent that it's possible to improve antimicrobial stewardship at the front line, at the point of care.
Thank you. Perhaps one last question to our speakers. Sarah Collins, she says she's working with Nest 360, and she's wondering if you'll be looking to strengthen blood culture in facilities where the antibiotic trial will be based. Is that a question for you, Suba?
Yeah, so I think diagnostics are part and parcel of drug development. I mean, that we do. As Alex very nicely put it, you know, you can't do one without the other. And so I think definitely, diagnostics will be part of, although we are not diagnostic developers ourselves, we work in partnerships, and every one of our drug products will have some kind of initiative that will also promote diagnostics.
Let me then ask our speakers the 30-second Twitter question, because as I said, I'm hoping that our audience will be tweeting using the hashtag WAAW 2022 or @GARDP, which is a very simple question. Let me ask Alex and then Christina and Nishad and then Suba finally. Just what is your take-home message? How do we make sure that we put children and newborns first? Alex.
So I'm actually going to, so my message here is actually different from what I have said so far. I think COVID has taught us a number of lessons, and I think we should leverage these lessons. One of them is that I think we need to adopt a systems approach and really focus a bit more on decentralization of service provision, including primary healthcare. The question about point of care diagnostics, that's a very important one that can improve stewardship of the front line. I think we should consider adopting digital health technologies that are patient-centered, because they will improve diagnosis and treatment and stewardship of drugs at the front line. And I think we should also look at community health systems and linking all of these different things together in order to improve the kind of diagnosis and treatment that we have, particularly for children who do not have access to mainstream centralized health systems. Over to you.
Christina, how do we make sure that we really do put children and newborns first when it comes to drug-resistant infections?
So my key takeaway is that antibiotic clinical trials among neonates are urgently needed in order to optimize treatment outcomes. And alongside that, we need to implement measures that will be useful in preventing the spread of infection among babies. And so some of these measures that we need to look into include implementation of evidence-based infection prevention and control interventions, and also looking into cohorting the very sick and the less sick babies with early or prompt discharge home of those babies who are stable and have completed the antibiotic treatment. And the other measure that you can look into has to do with improving staffing capacity within the maternity wards and the neonatal units.
Yeah. Thank you, Christina. Nishad.
I think Shubhashree said this better than I can, and she mentioned that and newborns and children should be included in the process of right from the point when we are developing antibiotics, not as an afterthought. They are a smaller market than adults are, but I think they need to be in our minds when we develop new drugs, new antimicrobials.
Suba, I imagine you're going to make exactly the same point, but over to you very briefly before we conclude.
Well, I'll make a broader point. So in my view, antimicrobial resistance and the degree of AMR is really an indicator of health disparities in the world today. And if we want to make a dent and create health equity, as has been expressed by many policymakers, I think it needs to begin with children. They are the citizens of tomorrow. And with that, I'll hand over back to you, Claire.
Well, thank you very much, Suba, Medical Director of GARDP, Alex Costa, Senior Health Advisor at UNICEF, Christina Obiero, Clinical Researcher at the Kemri Wellcome Trust Research Programme in Kenya, Nishad Plalakal, Professor of Neonatology at the Jawaharlal Institute of Postgraduate Medical Education and Research in India. Thank you very, very much for your insightful comments on how we should move forward and to put children and newborns, these very vulnerable groups, first when dealing with drug-resistant infections. And I would like to point out we have two side events that are coming up at the Second International Conference on Public Health in Africa in Kigali from the 12th to 15th of December. and one of them will focus on neonatal sepsis in Africa, while the second one will focus on access to antibiotics. You can see more of the details on the slide. And there is the antimicrobial chemotherapy virtual conference next February, and poster abstracts will close on the 25th of November. But for the moment, that's all from me, Claire Dool, and from our very, very distinguished speakers. And to your audience, thank you for those very, very informed questions. Goodbye.
Thank you.
Thank you.
Thank you.